Thank you very much. Assalamu alaikum and good afternoon to each and every one of you out here. Before I start my presentation, first of all, thank you, sir, for the invite and for being a fantastic mentor. I mean, I really believe that all my interest in Ramadan has actually been started and stemmed by sir. We just had a fantastic presentation by sir regarding, when do we monitor our patients during Ramadan. I think we all in this room and I think across the globe agree that monitoring forms a vital part of pre-Ramadan education. And monitoring also is one of the very, very important components that prevents both hyperglycemia as well as hypoglycemia and all the related complications which we expect during the fasting period. But does that always happen? Is that what we see in reality? I am going to actually move away from utopia. I wish we had such a lovely world where everything was perfect and all my patients did monitoring exactly the way I wanted them to do. But unfortunately, that doesn't happen. And what happens in the real world? This is what I'm going to talk about in the next few minutes assigned to me. What happens in all these various groups? This is an overview of my presentation. And we all know this. We've just been seeing these slides in the last few presentations. We also saw this as to when and how you would monitor your patients. But in the real world, this is what happens. These are some of the papers which I will rapidly run through before I actually go to the data which I want to be talking about. But across the globe, when you actually look at some of the studies where it has been evaluated at what kind of monitoring has been done, the number looks pretty reasonable. 56% of patients monitor themselves. That doesn't sound to me too bad, honestly. But when you look at the little bit of the more nitty-gritty, what comes across to you very, very categorically, you will realize is that only around 30% of the patients actually monitor themselves when they're hypoglycemic. Most of the patients, as we've been seeing and is being repeatedly pointed out, will check their sugars pre-iftar because I think we as clinicians believe that's the most important period. And hypoglycemia, I know, worries all of us more than hyperglycemia, though I know there would again be a divided opinion on that. But other than those periods, the rest of the periods, patients don't really tend to monitor themselves. What could be some of the reasons we'll think about? Also, it has been seen that if patients do not monitor themselves the way they should be, what results in also a significant degree of hyperglycemia. Across the board, whether you look across the globe, you look at this Malaysian study, again, similar data coming across. Participants' SMBG, not up to the mark, not according to the recommended guidelines. More than half practice SMBG, but most, mind you, are doing it only once a week, and that can be a significant risk factor for us in practice. Closer home, when you look at the data from our country and our neighbors, what do you see? 33%, mind you, do not have a glucometer and don't feel the need to buy one. They feel it's just not simply required. 58% did not monitor the sugars at all, and sometimes patients, in spite of having a glucometer, still don't do it. Coming to the DAR 2020 data, one very important point which came across in this entire data was that, yes, again, as I said, the numbers improved. 73% performed SMBG. But again, mind you, majority do it once a week. They may do it twice daily, 2 to 4 times weekly, once daily, or 3 to 4 times daily. Honestly, when I ask my patients, are you monitoring? And my patients, at the end of Ramadan, post-Eid, most of us, unless there's been some reason for us to go through those glucose charts, don't really go through them. At least I'm guilty of that. We don't tend to go through the details of it. If the patient has been fine, my diabetes educator says there's no major reason, we don't really go to and try to understand how often this patient has monitored. What has been the real impact of what pre-Ramadan education we did? And what comes across in this data, friends, is that majority of the patients, mind you, performed SMBG at the same rate that they did it before Ramadan. So when we are doing only pre-Ramadan education, are we somewhere missing the boat? Are we supposed to actually educate our patients all throughout the year regarding the importance of SMBG? Because unless we reiterate at every point of contact, when we try to do it just once before Ramadan, maybe we're just not making the kind of impact we should. And that's where somewhere I think our patients, and when we are not making that kind of impact, of course your patients are simply not going to follow what they should be doing. Are there studies which show that yes, close contact helps? A number of them, this is one of them. We know about type 1 diabetes, we just heard that. Again, inequitable monitoring. Monitoring which is not done the way it should be done. Data which says when you monitor your patients 4 to 5 times a day, it does help you. Patients do complete fasting period for almost 26 days successfully. Type 1 diabetic patients. CKD, another area where I went through a lot of data. And again, everywhere it shows frequent monitoring. It shows you're supposed to monitor more frequently, you're at a risk more. The DAR global CKD data very categorically says increased risk of hypo and hyperglycemia leading to hospitalizations, but no mention by us as to really how often our patients are actually monitoring themselves. Again, in cardiovascular disease and Ramadan, the same thing is reflected. Hypoglycemic events were significantly higher. We know when we talk about cardiovascular disease and hypoglycemia, there's a close link, but there's really no further evidence. So what did DAR 2022 really tell us differently? Was it something different that came across in the DAR 2022 data? My last few slides are totally dedicated to this because I think this is very important and we need to talk about it. I love this slide. When I first saw this slide, I loved it. I said, wow, 93% of type 1 diabetic patients globally are monitoring themselves. Super. My type 2 diabetic patients on insulin are monitoring themselves 77%, type 2 74%, and mind you, unfortunately, with drugs which we are saying do not cause increased risk of hypoglycemia, my patients in Ramadan have reduced their monitoring. We observed that data in the previous Ramadan because with the reduced use of sulfonylureas, patients are like, okay, I'm not monitoring the rest of the time. Ma'am said that this drug is very safe. Why am I being asked to monitor myself now? CKD type 1, 97.2%. That's super fantastic. Was my happiness really worth it? Was it short-lived? Unfortunately, it was. And the reason I said it is short-lived, because when you look at the number of patients who very, very emphatically in this database have told you that they have fasted, you would realize that only 23% actually monitor themselves more frequently than before Ramadan. 62%, yes, monitor at the same frequency as before Ramadan, but what is worrying is that less than once weekly and between 2 to 4 times to less than once weekly, you have almost 10 to 12%. Once daily, you have almost 10%, and only 50% of your patients, mind you, are monitoring 3 to 4 times daily. 7 points, we really don't have data out here as to whether patients are actually doing it 7 times. So what we are actually advocating as groups, and we do it very, very loudly, is sometimes not getting translated into clinical practice. So there's still that gap which we need to sort of bridge to be able to really make a difference in the real world. What about your type 2 diabetic patients? Similar kind of data comes across again over here. Over here, I would say that approximately 2 to 4 times weekly, we are around 17%. Almost 50% monitor themselves between that period. And again, over here, you would realize one very, very important thing is that 48%, that is again, almost half your cohort is monitoring at the same frequency as before Ramadan. So it's habits which form over the ages. It's habits which patients develop throughout the year, which are going to be translated into better monitoring during Ramadan. CKD type 1, a little worrying data again over here, because again 50%, and we already have spoken about CKD being a high risk factor for fasting during Ramadan. We are all the time saying that our patients with CKD need to monitor more carefully. But is it happening? Unfortunately, no. We still are facing situations where most of your patients, mind you, almost 50% are monitoring either twice daily, once daily, 2 to 4 times weekly, once weekly, and again less than once weekly. Only 23% of the patients of your CKD type 1 cohort is monitoring more frequently than before Ramadan. And we all know, yeah, I'm going to finish 2 more slides. I'll finish in time. And then when you look at CKD type 2, something very, very similar. CVD type 2, similar data across the board. And I think one of the factors when you look at the education below, you would realize that the education is most of the time in the clinic, not more than 15 minutes. 15 minutes is 70% of education. So if we are going to educate our patients for 15 minutes, I think we need backup. We need to train our staff. We need to have more train-the-trainer programs so that we can actually make a difference. When you look at patients on insulin, similar data across over there. Again, we're monitoring. So what we are increasingly looking at is monitoring, but we need to look more carefully at frequency of monitoring, because agreed that pre-Ramadan education remains a cornerstone, but we do still have limited data regarding the frequency of SMBG. Data shows, yes, performed, but not performed the way we wanted to. And I would like to reiterate, we need to educate our patients at all points of time. Thank you very, very much.